Hello, friends. I'm sure you would have heard about my reminiscences and my recollections of what I have learned and what I've gone through in the last 20 years as far as fluid therapy is concerned. And I'm sure you would have had your own thoughts and your own realizations that this has been a major paradigm shift in the field of intensive care. While I was thinking on that and while I dwelt upon that topic, I did make a passing mention about positive fluid balance versus its outcomes among in patients with ARDS. And I realized that ARDS is another area where there have been many paradigms and most of them have changed mostly for the improvement of outcomes among these patients. But is that really true? have have any of these newer aspects or the paradigm shifts really altered the mortality among patients with ARDS is something we all have to think about. If you look at ARDS in 20 years ago, it was just about emerging that it was a syndrome which included a non-cardiac source of alveolar infiltration with hypoxemic respiratory failure. From then on, it has progressed to what it is today, where we know that there is something called as or what we believe there is an L phenotype and a H phenotype, and each one behaves a little differently. But probably the most important paradigm shift regarding ARDS has been in its definition per se. When we were training in ARDS, the then definition spoke about ruling out a cardiac cause of the respiratory problem with the use of either an invasive pulmonary artery catheter or the use of an echocardiogram. From then on, we have progressed to what we then realized about 10 years ago about the Berlin definition of ARDS and the necessity for doing a CT scan for these patients to fit them into a diagnosis of ARDS. Subsequently, it has been felt that in resource limited areas and in developing countries and low and middle income countries, the blanket application of CT scan may not always be feasible, and a good number of these patients who are potentially ARDS patients would drop out from the diagnosis, and therefore the strategic management for ARDS because of the non-availability of a key diagnostic tool. That prompted the Kigali modification of the Berlin definition, but this particular modification has not actually been widely accepted, and still the Berlin definition seems to be the mainstay for diagnosing patients with ARDS. So the major paradigm that shifted is basically from the diagnosis of ARDS, and we have brought in the concept of rating it based on the PaO2 by FiO2 ratio, and what has gone out of the armamentarium or from the description of hypoxemic respiratory failure is the concept of acute lung injury. Having said that, certain older definitions like transfusion related acute lung injury still persist. So what do you call those hypoxemic respiratory failures that are happening as a result of transfusion? So still I think there is a scope for improvement of the definition of ARDS. In my perspective as a student and then as a junior consultant and currently now as a teacher and an intensivist of 20 years standing, I personally feel the biggest game changer in the management of patients who are mechanically ventilated has been the realization that high tidal volumes are detrimental even in the non-ARDS lung. When we started our training in 2002-2003, it was just coming into the realm of intensive care that 6 to 8 mils per kilogram of ideal body weight of tidal volume is probably safe, is probably good, and is probably the better way of ventilating patients with ARDS. Prior to that, even in the ARDS-NET studies and other studies in ARDS, the tidal volumes which were delivered were close to 15 mils per kilogram of ideal body weight. And in fact, the original studies on ARDS, which compared the low tidal volume with the conventional tidal volume, use 10 to 12 mils per kilogram ideal body weight of tidal volume, and critics therefore feel that is responsible for the mortality benefit which the lower tidal volumes have actually shown. As a corollary or as a side activity, these studies have also shown that higher tidal volumes are associated with an increased concentration of biomarkers in the bronchoalveolar lavage fluid. While we have seen the impact of biomarkers and followed them fastidiously during the COVID pandemic, it was in 2009, it was when it was first described that patients who are ventilated with higher than 8 mils per kilogram body weight have a higher concentration of interleukin 6 and interleukin 12 in the bronchoalveolar lavage fluid, suggesting that mechanical ventilation itself is a cause of biotrauma. So, the paradigm from then progressed to low tidal volume ventilation to the point that we came to 6 to 8 mils per kilogram tidal volume per kilogram of ideal body weight tidal volume. To the point now we have reached a stage with the availability of extracorporeal blood purification techniques including ECMO and ECCO2R, we now are saying that ultra low tidal volumes are also feasible and are safe among patients with ARDS, which means tidal volumes as low as 4 mils per kilogram ideal body weight have been applied with no detrimental effect, but they are yet to show unequivocal mortality benefit. So 4 mils is supposed to be something that is workable and that is something that is implementable among patients with ARDS. So that's a major paradigm shift. So nearly 70% decrease in the tidal volumes which you are delivering to patients compared to what we were doing in the year 1999 and 2000. The second parameter, which has probably kept pace with the tidal volume, but which was used for quite a long time in probably inappropriately high numbers in inappropriate subset of patients, is PEEP. When I began my career in intensive care, it was not unusual to find patients with ARDS being ventilated with PEEP of 15 and 16. Some of them survived, some of them didn't survive. Some of them probably had air leaks, not a full-blown pneumothorax, but definitely pneumomediastinum. We never picked it up. But there were times when patients were ventilated even up to PEEPs of 20 and 22. And the ARDS-NET study, the PEEP table also used this level of PEEP for quite some time. For about a decade after that, it continued to be used and people were being ventilated with PEEPs of 15 and 16. But consequently, subsequent publications, subsequent understanding has probably educated us that a PEEP of more than 12 is probably no more beneficial than a PEEP of 10 to 12. So identifying the optimum PEEP and ventilating patients with an acceptable PEEP is probably another major paradigm shift which has influenced the outcome among patients with ARDS. There are multiple reasons for that. We have now got better tools to image the lungs. We have now got better understanding of the mechanics, and we also know, as we will discuss, as we will dwell upon later, about the driving pressure and its correlation with an increasing PEEP. But PEEP always does not confer a better aeration of the lung, and better oxygenation is an understanding we have realized over the last 20 years, and now we have come to a stage of low tidal volume to ultra low tidal volume with our optimum PEEP not crossing maximum 14 millimeters of mercury. The third paradigm, which probably has waxed and waned, had a big fan following in the early part of 2000 to 2006, 2007, and then became a little skeptic about it, and then probably is now falling out of favor, is recruitment manual. When I was a trainee in intensive care in 2002 and 2003, we used to very animatedly discuss about the ways of recruitment. What is the best way of recruitment? Should you recruit with CPAP? Should you recruit with pressure control? And then we used to practice it. We used to follow our seniors, our teachers. They used to show us how to recruit patients. And in the early days of prone ventilation, which again we will discuss in a little bit of detail shortly, If you have pruned a patient and have not recruited it, it was considered as incomplete treatment of the patient. So recruitment became a very standard practice for all comers of patients with ARDS. Then somewhere along the line, publications came in which said that there are two types of ARDS, a heterogeneous or an extrapulmonary ARDS and a homogeneous and a pulmonary ARDS, one of which is recruitable and one of which is non-recruitable. And we tried to use a lot of explanations to say that a homogeneous in a homogeneous lung, recruitment is probably good, and in a heterogeneous lung, the recruitment is probably not good. And that philosophy persisted till the FAR lab study proved that recruitment can be harmful for all patients with ARDS, and it's a very, very selective group under invasive hemodynamic monitoring who will benefit with the use of these recruitment maneuvers. But there is no hard evidence in published critical care literature which argues strongly that patients who are refractorily hypoxemic will get better with recruitment maneuvers. Of course, inverse ratio ventilation, prone ventilation, and probably APRV are all subtle types of recruitment maneuvers, but recruiting the lung with pressure seems to be something that has fallen out of vogue, and you will have to do it in under really pressing circumstances with meticulous monitoring whatever you use. So after recruitment or before recruitment or at the same time as the recruitment came into the picture, people started looking at prone ventilation. Prone ventilation is never something that's come out of the blue. It has been practiced before, it has been recommended before. As early as the late 70s, it was practiced among critically ill ARDS patients. But prone ventilation as a strategy for patients who are refractorily hypoxemic started coming into the mainstream of management of these patients in the early part of my career as an intensivist. But we did not know how long you should prone these patients, how long you can leave them in the prone position, and how many times you should prone these patients. So we proned quite a few patients, maybe for 4 hours and 6 hours, and then said yes, he's not getting better or he's getting better, and maybe we supined them too fast, so our results were not as good as what they are currently when you prone patients with severe refractory hypoxemic respiratory failure. Now, prone ventilation has got several benefits. Most of you are aware of it. But if you go back to evolution, the simplest way of thinking is we all evolved as four-legged animals. So the basal part of the lung or the upper part of the lung when you're walking on 4 legs is the one that is actually being brought into play when you prone patients in the context of ARDS. So prone ventilation has shown, the ProSeva study and subsequent other replicatory studies have shown that there is a mortality benefit among patients with hypoxemic respiratory failure if you prone them early, prone them long enough, and subject these patients to repeated episodes of proning. In the initial stages of prone ventilation, there were concerns that you could your vascular accesses could be a problem, your dialysis, your catheter insertions could be a problem, your airway could be a problem. But over a period of time, we have learned to manage these hard housekeeping activities very well. Teams have become very conversant with the art of proning to the point that we are now subjecting patients in prone ventilation to ECMO as well. So this has also been a major game changer in the management of ARDS as far as paradigm shifts is concerned. While we always speak about PEEP, tidal volume, recruitment maneuver, the focus from about 20 years ago has been on the plateau pressure. And we always have believed that the plateau pressure is a marker of the compliance. So a worsening plateau pressure is a marker of worsening compliance. So as your plateau pressures get better, your patient is improving, and if you cross a particular number of plateau pressure, your ventilatory settings are probably inappropriate for ARDS. So that remained as the gold standard number to be taught, to be practiced, and to be followed in intensive care. until about 5 years ago when the driving pressure came into the picture. Now, this driving pressure equated the plateau pressure and the PEEP and said that what your PEEP is doing to the rest of the respiratory mechanics is reflected in the driving pressure, and you can up your PEEP if there is no compromise in driving pressure, and that solved two problems. It gave you a number beyond plateau pressure, and it also told you how to identify the acceptable PEEP for a particular patient, and also to understand what is harmful PEEP. So the emergence of driving pressure and getting a number for it, like a 12 or a 13 or a 14 for the cap for driving pressure to be reflective of the success or failure of your patient with mechanical ventilation, seems to be another major paradigm shift, and it has now become standard practice to record driving pressures in your monitoring charts for all patients with ARDS. About 3-4 years ago, while we were just before the COVID pandemic started, interesting concept of mechanical power came into the picture, and this power looked at the delivery of force over a period of time to a fixed surface area, which means that energy is being delivered to the lung. So since energy cannot be lost anywhere, it dissipates, and it is the lung that absorbs this energy, and the more energy you dissipate to the lung without doing effective work, the more damage you are going to do. So mechanical power as a surrogate reflection of your inappropriate ventilatory strategies or your appropriate ventilatory strategies has been another paradigm shift which has come into the field of mechanical ventilation. When you go back to low tidal volume ventilation, when you go back to optimum PEEP mechanical ventilation, and when you go back to moderate driving pressure mechanical ventilation, the whole purpose or the whole focus has been on what was called as lung protective ventilatory strategy. This was the mantra for any answer or any query regarding how do you ventilate a patient with ARDS. The answer would be a standard set of lung protective ventilatory strategies with low tidal volume, optimum PEEP, and acceptable driving pressure. But that probably seems to be a very focused or a tubular vision directed approach to mechanical ventilation, because mechanical ventilation, when you ventilate the lung, the impact is not borne only by the lung but by other structures as well, predominantly the thoracic structures, the heart, the intercostal muscles, and the diaphragm, but also the extrathoracic structures like the kidney and the brain. So it is not, and considering the fact that the heart and lung are very intrinsically connected and work like in very significant synchrony, heart-lung interactions and the effects of mechanical ventilation on the functioning of the heart became an integral part of protective ventilation. So from lung protective, we went into lung and right ventricular protective ventilatory strategy. We can't leave it at that. The diaphragm is an important player, whether the patient is on a controlled mode of ventilation or whether the patient is on a spontaneous mode of ventilation. The diaphragm is an integral and a crucial player in this act of respiration and the subsequent liberation of the patient from mechanical ventilation. So, diaphragm protective ventilatory strategy then came into the picture, and this actually correlates to the pressure support you give to these patients with mechanical ventilation. We were always believed that if the patient is tiring out, he is not synchronizing well, maybe if you increase the pressure support, he will settle down. Now that concept is not always 100% true. If you give more pressure support to the patient and he hyperinflates its lung, the brunt is borne by the diaphragm, and this is what is called as over-assistance myotrauma, and such patients will definitely end up with having weaning failure. So this understanding of myotrauma has brought into focus the diaphragm protective ventilatory strategy. So when you talk about protective ventilation at this point of time, 20 years down the road, what I personally feel is that it is lung, it is right ventricular and diaphragmatic protective strategies which have to be discussed in tandem when you say how do you ventilate patients with ARDS. So this concept of right ventricle has uh, come into the picture, and that brings us to the discussion about our old friend, the central venous pressure. I will reserve my contemplations and my reminiscence of CVP for another day, but it is probably going to come back into the monitoring system of ventilation, not hemodynamics, on the simple point that an incremental peak, which probably causes an increase in the CVP, is a marker of adverse right ventricular response to mechanical ventilation. We have to wait and see whether this paradigm actually changes. One of the important aspects of managing patients with ARDS is that it is not always ventilatory and associated strategies. Non-ventilatory strategies are also integral players in the successful outcome for patients with ARDS. And in that, the steroids have been sometimes the heroes, quite often the villains, and sometimes the character artists in uh, the management of ARDS. In 2001-2002, the Meduri protocol was rampantly used for management of these patients, and this actually necessitated the use of methylprednisolone for almost 4 weeks after the diagnosis of ARDS was concerned. We do not know how many of these patients ended up with fungal infections, how many of them ended up with critical illness polyneuropathy, but the Meduri protocol was used quite often in those days. Subsequently, of course, the late ARDS steroid rescue studies said that do not start them after the first week, and then subsequent data seems to suggest that probably except for a small cohort of patients with viral pneumonia, the role of steroids is limited. So the disappearance of steroids from the armamentarium of medications used for treating patients with ARDS has been a major paradigm shift as well. Lastly, the advent of sonography. Now, as with all aspects of intensive care, whether it's neuromonitoring, whether it's hemodynamic monitoring, whether it is fluid assessment, the role of sonography has come into the picture for assessing patients who have early ARDS. You pick up the fractal signs, you pick up the profiles, you subject them to recruitment and you see whether the lung is getting better. You prone the patient and see the change in profile. You look at the diaphragm, its thickness, its shortening fraction, and you can look at the right ventricle, and you can also identify fluid overload, which is detrimental among patients with ARDS. So friends, I still feel ARDS paradigms are shifting. We may have new paradigms 10 years from now. I may not be around, but somebody else will recollect what has happened in 2023 and talk about it in 2033. But there have been several paradigms like optimal tidal volume, the advent of driving pressure, moderation of PEEP, the use of prone ventilation, the early short-term use of neuromuscular blockade, the concept of driving pressure, a global protective strategy rather than the lung protective ventilatory strategy, and of course the use of sonography. So ARDS is one area where I feel some paradigms have shifted in my last 20 years of intensive care. So please think about it and just message or let me know what your thoughts are on this aspect of the paradigm shift that has happened in a crucial area of intensive care. Thank you very much. We will meet again short in the next set of. As I keep thinking, maybe I will get some more ideas, some more paradigms that have shifted, and will get back to you.